She had already started giving things away. Not because she was moving, not because she was clearing out clutter, because her daughters had taken her to a specialist, and the specialist had said the word Alzheimer's and Margaret, who had organized her kitchen by seasonal preserves and her bookshelves by decade, and her memory by the face of every student she'd ever taught in 31 years, had decided it was time to let things go before they were gone from her mind entirely. The jewelry her mother had left her, the recipe box she'd kept since 1974, the photograph albums. Distributed quietly while she could still explain what each thing meant and who it had belonged to. She was 70 years old. And she was preparing to disappear. Here is what nobody knew, including Margaret, including her daughters, including the 3 physicians who had seen her over 18 months until a geriatrician reviewed her medication list. Margaret had Alzheimer's. And she also had something else. Something that, when it was addressed, began to lift the fog the Alzheimer's diagnosis had placed over everything, including the question of how much of her cognitive decline was the disease and how much was the medicine cabinet. I'm Dr. Ben, and this video is about the question that doesn't get asked often enough, in rooms that matter too much. Not, do you have Alzheimer's? But, could any of this be the medicine cabinet? Stay with me. Because by the end of this video, you are going to understand exactly how to make sure that question gets asked and answered before the most irreversible decisions get made. Let me tell you where Margaret's medication list started. She had 8 prescriptions, each one prescribed by a different physician for a legitimate reason at a different point in her life. Her cardiologist had prescribed a beta blocker and a diuretic for her blood pressure. Her GP had prescribed a sleeping aid diphenhydramine, the antihistamine-based sleep drug, and Benadryl and Zizquil because she'd had trouble sleeping since her husband died 2 years earlier. Her allergist had given her a prescription antihistamine for seasonal hay fever. Her urologist had prescribed oxybutynin for overactive bladder. Her GP had added a low-dose antidepressant amitriptyline, a tricyclic, for her grief. 8 medications. 5 separate prescribing physicians. Not one of them had seen all 8 at the same time, and buried in that list were 4 medications with significant anticholinergic properties. Diphenhydramine, the sleep aid, rated 2 on the anticholinergic cognitive burden scale. The prescription antihistamine rated 1. Oxybutynin rated 3. Amitriptyline rated 3. Combined anticholinergic burden score 9, a score the research literature has consistently associated with measurable cognitive impairment, brain atrophy on imaging, and substantially elevated dementia risk. The American Geriatric Society's 2023 Beers Criteria, the Clinical, guideline used by geriatricians and pharmacists to identify potentially inappropriate medications in older adults explicitly states that combinations of 2 or more medications with strong anticholinergic properties should be avoided in older adults. Margaret had 4, and they had been renewed automatically at each appointment because each specialist was managing their piece of the picture without any single person seeing the whole. A study of older adults attending memory clinics found that nearly half, 47%, were taking at least one potentially inappropriate medication based on the Beers criteria. Nearly half. In a memory clinic. The population being evaluated specifically for cognitive decline. This is the structural problem this video exists to name. The geriatrician who eventually saw Margaret referred by her eldest daughter, who had spent 3 months researching reversible causes of dementia after finding a medical review article she couldn't stop thinking about, did not dispute the Alzheimer's diagnosis. The biomarkers were consistent with early Alzheimer's disease. The cognitive testing was clear. The neurologist's assessment was not wrong. What the geriatrician said was this: Alzheimer's and a medication burden score of 9 are not mutually exclusive, and we will never know how much of what you're experiencing is the disease and how much is the pharmacology if we don't systematically address the pharmacology first. That sentence is the reason I'm making this video, because the geriatrician was right. The brain on Alzheimer's disease plus an anticholinergic burden of 9 is not the same brain as the brain on Alzheimer's disease alone. And distinguishing between those two states, finding out how much of what looks like disease progression is actually medication burden, is only possible if someone reviews the whole list with that specific question in mind. In Margaret's case, the review took 90 minutes. The geriatrician went through every medication, its indication, its duration, its alternatives. She contacted each prescribing physician with a summary of the anticholinergic burden and a proposed deprescribing plan. She was careful and specific, not replacing medications with nothing, but replacing high-burden medications with lower-burden alternatives where clinical equivalence existed. Margaret asked her geriatrician one question at the end of that appointment. She said, "Even if this helps, am I past the point where the list matters?" The geriatrician said, "We won't know until we try. But I have never seen a case where knowing was worse than not knowing." The sleep aid was switched to melatonin and a referral to CBTI, the behavioral therapy for insomnia that the American College of Physicians designates as the first-line treatment for chronic insomnia, above medication. The antihistamine for allergies was switched to loratadine, a second-generation antihistamine with no meaningful anticholinergic burden. The oxybutynin for her bladder was switched to mirabegron, a non-anticholinergic alternative specifically studied for this population. The amitriptyline was reviewed with her GP, and a plan was made to transition to a selective serotonin reuptake inhibitor, which carries far lower anticholinergic burden. The process took 3 months. Careful, monitored, documented, and during those 3 months, Margaret's daughters noticed something that none of them had expected to see. She wasn't cured. Nobody said she was cured. Nobody used that word. But the fog had thinned. She was finishing sentences she had been leaving incomplete for a year. She was asking about family news questions she had stopped asking when she stopped being able to follow the answers. She made a batch of the apricot jam her daughters had grown up with from the recipe box she had given away. Her daughter drove it over to her and found her reading in the kitchen with the radio on. Margaret described it herself when her geriatrician saw her at the 3-month follow-up. She said, "I still have the disease. I know that. But I feel more like myself than I have in 2 years. There's more of me here than there was. There's more of me here than there was." The geriatrician wrote that in her notes. Now, what does this mean for you, or for someone you love who has received a dementia diagnosis? It means 2 things, and I want to be precise about both. First, a dementia diagnosis and a medication burden problem are not mutually exclusive. Many people who have Alzheimer's disease are also carrying an anticholinergic burden that is amplifying their symptoms beyond what the disease alone would produce. Finding and addressing that burden does not cure the disease, but it may reveal how much of what is being attributed to the disease is actually being driven by the pharmacology, and that distinction matters profoundly for quality of life, for care planning, and for the understanding of how fast the disease is actually progressing. Second, the standard initial evaluation for dementia cognitive testing, brain imaging, blood panel does not include a systematic anticholinergic burden review. That review is what geriatricians do. It is not automatically what happens in a neurology or primary care appointment focused on cognitive assessment. It requires someone to look at every medication, calculate the combined burden, and ask the specific question, could any of this be driving what we're seeing? That review does not happen automatically. It happens when someone asks for it. Here is the question to bring to your next appointment, or to bring on behalf of someone you love. Has the anticholinergic burden of the complete medication list been calculated? I'm asking specifically whether any combination of medications with anticholinergic properties, including over-the-counter sleep aids, antihistamines, bladder medications, or antidepressants, could be contributing to the cognitive symptoms we're seeing. And if that review hasn't been done, I'd like to request a referral to a geriatrician for a comprehensive medication review. That question is specific. It names the mechanism. It names the drug classes, and it names the referral path a geriatrician, not another neurologist. Because the geriatrician's training specifically includes polypharmacy assessment in the way that not all neurology training does. Margaret's recipe box is back in her kitchen. She didn't retrieve it. Her daughter found it in a drawer and put it back without asking, and Margaret didn't correct her, which, her daughter told me later, was the first sign that something had shifted. The old Margaret would have known exactly which drawer it had gone into and why. She still has Alzheimer's disease. That is real, and it is not going away. But the version of Margaret who is living with it now is more present than the version who was living with it before. Because one geriatrician, in one 90-minute appointment, asked the question that nobody else had asked. Could any of this be the medicine cabinet? In the next video, I want to bring this entire series to its conclusion with something that changes the scale of what we've been discussing. In July 2025, a 2-year randomized clinical trial involving over 2,000 older adults at risk for cognitive decline across 5 academic medical centers in the United States published its results simultaneously in JAMA and at the Alzheimer's Association International Conference in Toronto. The trial is called US. Pointer. It was the first large-scale study to test what happens when all the interventions we've covered in this series, diet, exercise, cognitive challenge, cardiovascular risk management, are combined and delivered simultaneously in a structured program to people who are already at elevated risk for dementia. The results changed what researchers thought they knew about how far cognitive protection can go. Not in animals, not in a single small study, in over 2,000 people, in a randomized controlled trial. Published in JAMA. That's the next video. Subscribe so you don't miss it. And if you know a family that is navigating a dementia diagnosis right now and the full medication list has never been reviewed by a geriatrician, share this with them. Not to give them false hope, to make sure every question has been asked before the final picture is accepted. I'm Dr. Ben. I'll see you in the next one. The information in this video is for educational purposes only and does not constitute medical advice. Always consult your doctor or a qualified healthcare professional before making any changes to your medications or treatment plan. A dementia diagnosis requires evaluation by a qualified physician.